Okay, we're going to talk about antibiotics now. So, what are the mechanism of actions of antibiotics? Disruption of the bacterial cell wall, inhibition of protein synthesis, inhibition of folic acid synthesis. Alright, tell me some things that may cause antibiotic misuse and resistance. Using for viral infections, using when no infection is present, using antibiotics incorrectly, and skipping doses or not taking the whole antibiotic regimen. Alright, what do we use narrow spectrum antibiotics for? Usually just for one bacteria type. Give me some examples of narrow spectrum antibiotics. Penicillin and erythromycin. What do we use broad spectrum antibiotics for? Usually gram-positive and gram-negative bacteria. We use them to treat infections when the offending microorganism has not been identified by culture and sensitivity. What are some examples of broad spectrum antibiotics? Tetracycline and Cephalosporins. What are the major downsides to broad spectrum antibiotics? Developing resistance, a lot more side effects, and can cause a lot more toxicity. Alright, so what would you see with the mild allergic reactions? Rash, pruritus, and hives. What would you see with severe allergies or anaphylactic shock? Bronchospasm, laryngeal edema, vascular collapse, cardiac arrest. How do you treat allergic reactions? Antihistamines, epinephrine, steroids, bronchodilators. Okay. What is the drug class of penicillin? Penicillin. What is the action of penicillin? Infection. What are side and adverse effects of penicillin? Nausea, vomiting, and diarrhea. What do we need to know about when taking penicillin? Most likely for people to be allergic to, but they are cheap. Take entire course of antibiotics. If allergic, wear a med alert bracelet. Increase fluid intake. Full glass of water with med because it can cause you to have crystals in your urine. Take with food to prevent GI upset, and use a backup method of contraceptive. Alright, cephalosporins. Give me some examples of cephalosporins. Ceftriaxone and cephalexin. What are cephalosporins used for? Infections. What are the major side and adverse effects of cephalosporins? High risk of C. diff. What are you going to take with cephalosporins? Foods high in probiotics or probiotic supplements. What do we know about IM cephalosporins? They're painful, and you're going to mix them with lidocaine. What do we know about IV cephalosporins? I'm going to give these slow push or piggyback. Alright, how do we administer vancomycin? IV or orally for C. diff. What is vancomycin used for? Serious infections like MRSA and then PO for C. diff. What are the major side and adverse effects of vancomycin? Major renal toxicity and then flushing if you give IV too fast, which is like red man syndrome. So, when we give it IV, how are we going to give it? Slowly. What things are we going to monitor when someone's taking vancomycin? We're going to monitor the kidney, so like BUN, creatinine, and urine output. Then we're going to monitor peak and trough levels, peak being 1 hour after, and trough being 30 minutes before dose. All right, fluoroquinolones. Give me some examples of fluoroquinolones. Levofloxacin and ciprofloxacin. All right, fluoroquinolones. What are the side and adverse effects of fluoroquinolones? Hepatotoxic, nephrotoxic, and Stevens-Johnson syndromes. All right, what meds do fluoroquinolones interact with? NSAIDs, because if you take them together, you get seizures. And then these will increase the effects of oral diabetes meds. And then you want to take these 2 hours apart from antacids, iron, and dairy. All right, tetracyclines. Give me some examples of tetracyclines. Doxycycline and tetracycline. What are the main side and adverse effects of tetracyclines? Hepatotoxicity, renal toxicity, phototoxicity. So, when it comes to eating food, when should you give tetracyclines? One hour before or 2 hours after food. So, there are certain types of people who should not get tetracyclines. Who do you think they would be? Pregnant women, and then children under 8 because they could get discolored teeth. What types of drugs or food should not be taken with tetracyclines? Don't take them with digoxin or warfarin because they increase the effects, and don't have dairy, iron, and acids as well. All right, macrolides. Give me some examples of macrolides. Erythromycin, clindamycin, and azithromycin. What are macrolides used for? Can get into bones to treat infections. What are the side and adverse effects of macrolides? Hepatotoxic, nausea, vomiting, diarrhea, and clindamycin potentially cause C. diff. So, when taking macrolides, what are you going to take these with? Full glass of water. What drugs or food interact with macrolides? Well, if you take digoxin and warfarin will be increased, their effects will be, then you want to avoid antacids. All right, amino glycosides. Give me an example of amino glycoside. Gentamicin. What are we using amino glycosides for? Serious or resistant infections. What are the side and adverse effects of amino glycosides? Autotoxic and nephrotoxic. What are we monitoring when we're taking amino glycosides? Urine output should be greater than 600 milliliters a day, and you want to draw peak and trough. All right, sulfonamides. Give me an example of some sulfonamides. TMP-SMZ. What are side and adverse effects of sulfonamides? Bone marrow depression, Stevens-Johnson syndrome, nephrotoxicity, phototoxicity. What are sulfonamides contraindicated in? Last 3 months of pregnancy. What food or drugs interact with sulfonamides? Antacids because they decrease absorption. Okay, going back over, antibiotics' mechanism of action is disruption of bacterial cell wall, inhibition of protein or folic acid synthesis. We also have antibiotic resistance is natural or inherent resistance. Acquired resistance is the more you expose a particular drug, the more chances you give the bacteria to develop resistance to that drug. Nosocomial infections are infections that are acquired in the hospital. Cross resistance is basically if you're resistant to one class, you may be able to develop resistance to another class as well. Antibiotic misuse and resistance, like using for viral infections, using when no infections are present, using antibiotics incorrectly, skipping doses or not taking the whole antibiotic regimen. Narrow spectrum are primarily effective against one bacteria type, and some examples would be like penicillin and erythromycin. Broad spectrum antibiotics are effective against gram-positive and gram-negative. For some examples would be tetracycline and cephalosporins. Frequently used to treat infections when the offending microorganism has not been identified by culture and sensitivity, but the downsides are developing resistance, lots of side effects, and more toxicity. Mild allergic reactions include rash, pruritus, and hives, with severe allergy and anaphylactic shock including bronchospasm, laryngeal edema, vascular collapse, cardiac arrest, and you're going to treat allergic reactions with antihistamines, epinephrine, steroids, and bronchodilators. Superinfections, secondary infections when the normal flora is killed. Importance of probiotics is to maintain normal flora, but make sure you space these guys out at least 2 hours apart with antibiotics, because they'll cancel each other out. Okay. With penicillin, you're going to use it for infection. Side and adverse effects of penicillin will be nausea, vomiting, diarrhea. People are most likely to be allergic to penicillin. However, penicillins are relatively cheap. You want to take the entire course of penicillin. If you're allergic to penicillin, wear that bracelet. With penicillins, you want to increase fluid intake, taking a full glass of water with penicillin to avoid crystals. Take penicillin with food, and if you're taking penicillin, you need a backup method of contraceptive. With cephalosporins, you got ceftriaxone or cephalexin. Cephalosporins are used for infection. However, they can cause C. diff, very high risk of causing C. diff. With cephalosporins, you want to take some type of probiotic with them. 2 hours apart. Remember, IM cephalosporin is painful. You want to take a lidocaine, but IV cephalosporin, give slow push or piggyback. Vancomycin, you give IV, or for C. diff, you take orally. Vancomycin is used for serious infections like MRSA and then C. diff as well. With vancomycin, it can cause renal toxicity and flushing if you give too fast. It's like red man syndrome. Vancomycin, you want to give it IV slowly, and you want to monitor the kidneys, like the bun, creatine, and output. You want to get the peak and trough levels, peak being 1 hour after, trough being 30 minutes before. Fluoroquinolones, you got levofloxacin and ciprofloxacin. With fluoroquinolones, they can be hepatotoxic, nephrotoxic, and cause Stevens-Johnson syndrome. You want to avoid NSAIDs because if you take them together, you could get seizures. They increase the effects of oral diabetes meds, and you want to take them 2 hours apart from antacids, iron, and dairy. You want to encourage fluids, at least 2,000 milliliters because of crystalluria. Tetracyclines, you got doxycycline and tetracycline. They can cause hepatotoxicity, renal toxicity, and phototoxicity. Tetracyclines increase the effects of digoxin and warfarin. With tetracyclines, you don't want to take dairy, iron, and acids because tetracyclines like to bind to iron and calcium so it won't get absorbed. Tetracyclines, and when you eat, you want to give these 1 hour before or 2 hours after food. And then tetracyclines should not be given to children under 8 years old because it can bind to the calcium in their teeth and discolor them. And then you also don't want to give tetracyclines to pregnant women. With macrolides, you got erythromycin, clindamycin, and azithromycin. Macrolides are used to get into bones to treat infection. However, they can cause hepatotoxicity. They can also cause nausea, vomiting, diarrhea. And clindamycin correlates with C. diff. Macrolides increase the effects of digoxin and warfarin. And when you take macrolide, you want to give with a full glass of water. And with macrolides, you want to avoid antacids. Amino Glycosides, you got gentamicin, and you're going to take amino glycosides for serious or resistant infections. Amino glycosides can cause ototoxicity or nephrotoxicity. With amino glycosides, you want to monitor output, making sure they have at least 600 milliliters a day urine output, and you need to get peak and trough levels. With sulfonamides, you got TMP-SMZ. Sulfonamides can cause bone marrow depression, seizures, Stevens-Johnson syndrome, nephrotoxicity, and phototoxicity. With sulfonamides, you want to encourage fluids and monitor the urine output. These are contraindicated during the last 3 months of pregnancy. With sulfonamides, antacids decrease the absorption of them. Let's fucking go. Let's fucking go. Let's fucking go, boy. Get her done, boy. I'm working out soon, I promise. Soon. I promise. It ain't paused. What? Now we're gonna go over glucose reg. All right. What is insulin most commonly administered for? Type 1, type 2 diabetes. Where in the body is insulin released from? Beta cells. All right. What is the action of all insulins? Promote use of glucose by body cells, stores glucose as glycogen in muscles of the liver, and reduces blood glucose level. What drugs, if taken with insulin, may cause hypoglycemia? Aspirin, oral anticoagulants, alcohol, oral hypoglycemia, beta blockers, and tetracyclines. What drugs, if taken with insulin, may cause hyperglycemia? Thiazides, glucocorticoids, oral contraceptives, thyroid drugs, and smoking. All right, hypoglycemia. What are the signs and symptoms? Headache, dizziness, confusion, slurred speech, hunger, nervousness, anxiety, agitation, tremors, lack of coordination, sweating, tachycardia, and seizures. First phase is hangry. Second phase, everything dropped to have decreased LOC. What are the side and symptoms of hyperglycemia? Extreme thirst, dry mucous membranes, poor skin turgor, polyuria, fruity breath, fatigue, tachycardia, Kussmaul's respirations. What are the 4 different ways to give insulin? Subcutaneously, pen, pump, and inhaler. Okay, are we going to give fast and long-acting insulin at the same time? Nope, you're going to draw them up in different syringes and you're going to inject them in different places. All right. Insulin Lispro or Humalog is a what type of insulin? It's a rapid-acting insulin. What is insulin Lispro used for? Hyperglycemia and diabetes. What are the side and adverse effects of insulin Lispro? Hypoglycemia. What do we need to know about when someone's taking insulin Lispro? You have to use it with a sliding scale. You have to give this with food. It acts fast. Always check blood sugar first. Look to see how much PO intake your patient has had. All right, insulin regular, Humulin R, is what type of insulin? It's a short-acting insulin. What do we use insulin regular for? Hyperglycemia and diabetes. What is the main side and adverse effect of insulin regular? Hypoglycemia. What do we need to know about when someone takes insulin regular? Make sure you give it 30 minutes before someone eats. It's cheaper. This is the only insulin you can give IV. And check blood sugar first and PO intake. Alright, Insulin Glargine. What type of insulin is this? It's a long-acting insulin. What is insulin Glargine used for? Hyperglycemia and diabetes. What is the main side and adverse effects of insulin Glargine? Hypoglycemia. What do we need to know about when someone takes insulin Glargine? Doesn't have a peak time. Always take it the same time every day. Take it even if you haven't eaten a lot, and it's expensive. Alright, glimepiride and glipizide. What type of class is this? Sulfonylurease. What are the G in glimepiride and glipizides used for? Type 2 diabetes. What are the main side and adverse effects of glimepiride and glipizide? Hypoglycemia, risk of developing cardiac arrhythmias, and you got a sulfa allergy. What do we need to know about when someone takes glimepiride and glipizide? Monitor glucose and don't combine with alcohol. Metformin is what class? Biguanides. What is metformin used for? Type 2 diabetes. What are the major side and adverse effects of metformin? Major severe reaction with IV contrast dye because they interact and cause renal damage. You also have diarrhea, GI upset, and metallic taste. What do we need to know about when someone takes metformin? Monitor glucose. Glucagon, what is that class? Glycanogenolytic drug. What is glucagon used for? Diabetes and hypoglycemia. What do we know about when someone takes glucagon? It's released by alpha cells. It increases blood sugar, and IM route is most common, but you can give it IV. 50% dextrose. What is that class? Monosaccharide. What do we use 50% dextrose for? Diabetes mellitus, unresponsive hypoglycemia, and hypoglycemia when NPO. What is the main side and adverse effect of 50% dextrose? Extravasation. What do we need to know about when someone takes extravasation, 50% dextrose? Assess IV site before and after administering. Recheck blood glucose in 10 to 15 minutes. Stay with patient to assess for LOC, and this is IV push dextrose. All right, levothyroxine or Synthroid. What is that drug class? Thyroid hormone. What is levothyroxine used for? Hypothyroidism. What are the major side and adverse effects of levothyroxine? They look like hyperthyroidism, so like nervousness, insomnia, weight loss, tremors, headache, nausea, vomiting, diarrhea, cramps, tachycardia, palpitations, hypertension, dysrhythmia, angina, thyroid crisis. All right. What do we need to know about when someone takes levothyroxine? Increases T3, T4, and metabolism. Increases warfarin effects, but decreases digoxin effects. Don't give to MI patient because this will speed up their heart rate. Excreted via kidneys, so decreased dose if they have renal disease. Don't give to them if they have hyperthyroidism. Monitor vital signs. Takes 1 to 2 weeks for good effects. Administer first thing in the morning before food. Check labels before using over-the-counter meds. Assess for/report symptoms of hyperthyroidism and encourage the med alert tag. Hydrocortisone. What is that class? Glucocorticoids. What is hydrocortisone used for? Adrenal insufficiency. What are the major side and adverse effects of hydrocortisone? Increased appetite, sweating, headache, flushing, mood changes, altered sleep, high heart rate, high blood pressure, hyperglycemia, abnormal fat deposits, muscle wasting, edema, glaucoma, peptic ulcers. What do we need to know about when someone takes hydrocortisone? Keep an emergency dose with you if you're in a stressful situation. If you're sick, you're going to be taking this for life. Don't skip doses or stop suddenly. Take in the morning with food. Monitor blood sugar and blood pressure. All right. What's the name of, what do rapid-acting insulins end in? Log. Are rapid-acting insulins clear or cloudy? Clear. How long does it take for rapid-acting insulins to kick in? 5 to 15 minutes. What is the peak time of rapid-acting insulin? 30 minutes to hour. How long does rapid-acting insulin last? 2 to 4 hours. All right, short-acting insulins. Are they clear or cloudy? Clear. If we look at a bottle of insulin, how do we know that's a short-acting insulin? There's an R on the bottle for regular. What's the hallmark signs of short-acting insulin? Cheap, easy to get, only one that can be given IV. How long does insulin take to kick in? This short-acting insulin takes to kick in 30 to 60 minutes. And what is the peak time of short-acting insulin? 30 to 60 minutes. How long does short-acting insulin last? 3 to 4 hours. Intermittent acting insulin. Is this clear or cloudy? Cloudy. If we look at a bottle of insulin, how do we know it's intermittent acting insulin? It's an N on the bottle. How long does intermittent acting insulin take to kick in? 2 to 4 hours. How long does it take to get to the peak time of intermittent acting insulin? 4 to 12 hours. How long does intermittent acting insulin last? 18 to 24 hours. All right, long-acting insulin or Glargine. Is this clear or cloudy? This is clear. How long does long-acting insulin take to kick in? 1 hour. How long does a long-acting insulin last? 24 hours. What are the hallmark characteristics of long-acting insulin? No peak time. Give it the same time every day. Read these combinations right now. Always give combination insulins with food. Okay. How are we going to store insulin? If you're going to have it for more than 1 month, refrigerator. Less than 1 month, room temp's okay. And if you take it out of the fridge, wait 30 minutes before injecting. Make sure you keep it out of direct sunlight or high temperatures. Alright, gonna run back through all these right now. Ready? Alright, insulin is most commonly administered med for type 1 and type 2 diabetes. It's released by beta cells of islets of Langerhans in the pancreas. It responds to increase in blood glucose. It promotes uptake of fatty acids, glucose, and amino acids. It converts glucose to glycogen for future glucose needs. Things to know about all insulins: promote use of glucose by body cells, store glucose as glycogen in muscles of the liver, reduces blood glucose level. Risk for hypoglycemia with aspirin, oral anticoagulants, alcohol, oral hypoglycemia, beta blockers, and tetracyclines. Don't drink alcohol because it drops your blood sugar really fast and keeps your liver from giving you more glycogen. Beta blockers mask the signs and symptoms of hypoglycemia because they chill you out and keep your heart rate and blood pressure low. Risk of hyperglycemia and lowered blood sugar control with thiazides, glucocorticoids, oral contraceptives, thyroid drugs, and smoking. Glucocorticoids/steroids instantly increase your blood sugar. Hypoglycemia, you'll have headache, dizziness, confusion, slurred speech, hunger, nervousness, anxiety, agitation, tremors, lack of coordination, sweating, tachycardia, seizures. There's 2 phases of hypoglycemia. First phase is hangry phase. Second phase, everything drops and you have decreased LOC. Hyperglycemia, you'll have extreme thirst, dry mucous membranes, poor skin turgor, polyuria, fruity breath, fatigue, tachycardia, and Kussmaul respirations. Different ways to give insulin: sub-Q, used in the hospital. For a pen, it's easier to see the units of insulin, so it's good for people to use at home to administer safely. With a pump, you change it every 3 days, so you don't have to stick yourself much, and you can program exactly how much you need, so you have more freedom. And there's an inhaler version, but that's less common. Long-acting takes a long time to break down and is gradually released into the bloodstream. Fast-acting is not a crystal, so it enters your bloodstream fast. You don't want to give them together. So insulin Lispro or Humalog is a rapid-acting insulin that's used for hyperglycemia and diabetes. Can cause low blood sugar, and you want to use this with a sliding scale. Give it with food. It acts fast, so check blood sugar first. Look to see how much PO intake your patients had. Insulin regular or human R is a short-acting insulin. It's used for hyperglycemia and diabetes. Can cause low blood sugar. Make sure you give it 30 minutes before someone eats. It's cheaper, and it's the only insulin you can give IV, so check blood sugar first and PO intake. Insulin Glargine is a long-acting insulin. It's used for hyperglycemia and diabetes. It can cause low blood sugar. Doesn't have a peak time. Always take it the same time every day. Take even if you haven't eaten a lot, and it's expensive. Glimepiride and glipizide is sulfonylurease. It's used to treat type 2 diabetes, but it can cause low blood sugar. You have to look for sulfa allergies, and you have a risk for developing cardiac arrhythmias. These stimulate pancreatic cells to release insulin, so you want to monitor glucose and don't combine with alcohol. Metformin is a biguanide. It's used for type 2 diabetes, but you can get a very severe reaction with IV contrast dye because they interact and cause renal damage 48 hours apart. It can also cause diarrhea, GI upset, and has a metallic taste. It decreases hepatic production and glucose from stored glycogen and increases insulin receptor sensitivity, so you want to monitor glucose. Glucagon is a glycogenolytic drug. It's used for diabetes and hypoglycemia, and it's treated by alpha cells. So you want to monitor glucose, obviously. An IM route is most common, can be given IM. 50% dextrose is a monosaccharide. It's used for DM, unresponsive hypoglycemia, and hypoglycemia when NPO. can cause extravasation, so you want to assess IV site before and after administration. You want to recheck blood glucose in 10 to 15 minutes after giving, and then stay with patient to assess for LOC and it's an IV push dextrose. Levothyroxine or Synthroid is the thyroid hormone. It's for hypothyroidism. Can cause hyperthyroidism side effects and symptoms like nervousness, insomnia, weight loss, tremors, headache, nausea, vomiting, diarrhea, cramps, tachycardia, palpitations, hypertension, dysrhythmias, angina, thyroid crisis. Levothyroxine increases T3, T4 metabolism, increases the warfarin effects, but decreases the digoxin effects. Don't give this to MI patients because this will speed up their heart rate. It's excreted via kidneys, so decrease dose if they have renal disease. Don't give if they have hyperthyroidism. You want to monitor vital signs. It takes 1 to 2 weeks for good effects to kick in. You want to administer this first thing in the morning before food, and you want to check labels before using over-the-counter meds. You want to assess for and report symptoms of hyperthyroidism, and you want to encourage that med alert tag. Hydrocortisone is a glucocorticoid. It's used for adrenal sufficiency, but it can cause increased appetite, sweating, headache, flushing, mood changes, altered sleep, high heart rate, high blood pressure, hyperglycemia, abnormal fat deposits, muscle wasting, edema, glaucoma, and peptic ulcers. You want to keep an emergency dose with you and take if you're in a stressful situation. If you are sick, you're going to need this for life. Don't skip doses or stop taking suddenly. Take in the morning with food. Monitor blood sugar and blood pressure. Rapid acting is insulin aspart or Lispro. They end in log. It's a clear insulin. Kicks in fast within 5 to 15 minutes. Peaks 30 minutes to an hour. Lasts 2 to 4 hours. So give before a person eats, but make sure food's in the room so they can eat it, because it kicks in fast. Short acting is insulin regular. This is a clear insulin. This is the R on the bottle for regular. It's cheap and easier to get, and is only insulin that can be given IV. Onset of action is 30 to 60 minutes. Peaks 30 to 60 minutes. Lasts 3 to 4 hours. Intermittent acting insulin, NPH, is cloudy. There's an N on the bottle. Onset of action is 2 to 4 hours. Peaks 4 to 12 hours. Lasts 18 to 24 hours. Long acting insulin is Glargine. It's clear. Takes 1 hour for onset of action. Does not have a peak. Lasts 24 hours. Big crystals and takes a while to break down, usually given at bedtime. Always give it the same time every day. In combination, composed of short and intermediate acting or rapid and intermediate acting. Humulin 70-30 is isophane NPH 70%, regular 30%. Insulin isophane NPH 50-50 is humulin NPH 50 and regular 50. And Humalog 70-25 is Lispro protamine 75% and Lispro 25%. Check vitals and glucose levels before giving insulin. Report if you have hypo or hyperglycemia. Teach compliance with diet, insulin, and exercise. Have client wear med alert tag. Teach how to check blood glucose. Teach how to administer insulin. Teach how to store insulin, so like place in the refrigerator if you're going to have it for more than a month. Room temperature is okay, less than a month. If you take it out of the fridge, wait 30 minutes before injecting, and avoid sunlight and high temperatures. Oral anti-diabetic drugs, sulfonyl urease, glimepiride, and glipizide, treat type 2 diabetes. It stimulates pancreatic beta cells to secrete more insulin. Contraindicated with sulfur allergies, so you want to monitor glucose. You have a risk for hypoglycemia, and don't combine it with alcohol. With big guanides like metformin, it decreases hepatic production of glucose from stored glycogen, increases insulin receptor sensitivity as well as peripheral glucose uptake to cellular level. Warning, no contrast IV dye. You want to monitor glucose and side effects of potentially diarrhea and metallic taste. Glucagon is a hyperglycemic hormone secreted by alpha cells. Increases blood sugar by stimulating glycogenolysis. It treats insulin-induced hypoglycemia when other methods providing glucose are not available. It's iron route is most common, but can be given IV. Then 50% dextrose, D50W, is IV push. It's for unresponsive or NPO hypoglycemia. You want to recheck blood glucose 10 to 15 minutes after giving. Stay with patient to assess the LOC. Assess IV site before and after administration. And extravasation can cause severe damage. Okay, thyroid function. What does thyroid function do? It regulates metabolism, heart function, and growth and development. What does the pituitary gland secrete? TSH. And what makes T3 and T4? TSH stimulated by the thyroid. So what happens to TSH, T3, and T4 with hypothyroidism? Increases TSH but decreases T3 and T4. What causes hypothyroidism? Dysfunction or surgical removal of the thyroid gland. What are the major complaints when patients come in with hypothyroidism? Low metabolism, low vital signs, and fatigue. All right, with hyperthyroidism, what happens to TSH, T3, and T4? Decrease TSH, but increase T3 and T4. What causes hyperthyroidism? Increased secretion of thyroid hormone, but may be an autoimmune disorder or tumors. What are the assessments you'll see with hyperthyroidism? High metabolism, vital signs, restlessness, and anxiety. All right, what do drugs for hyperthyroidism do? Increase T3, T4 metabolism. What do the drugs for, so these drugs, what do they interact with other drugs wise? It increases the effect of warfarin and lowers the effect of digoxin. What are drugs for hypothyroidism contraindicated in? MI, severe renal disease, and hyperthyroidism. What are the side effects of these drugs? They're kind of like hyperthyroidism, like nervousness, insomnia, weight loss, tremors, headache, nausea, vomiting, diarrhea, cramps, tachycardia, palpitations, hypertension, dysrhythmias, angina, and thyroid crisis. What are we going to do when people are taking these drugs for hypothyroidism? Monitor vitals, takes 1 to 2 weeks for good effects. Administer first thing in the morning before food. Check labels before using OTC meds. Assess for/report symptoms of hyperthyroidism and encourage the med alert tag. All right, what do the adrenal glands secrete? Glucocorticoids and mineralocorticoids. What do glucocorticoids do? Increase glucose availability, break down protein, maintain vital signs, and affect mood and stress. How do we get the physiologic dosing of glucocorticoids? Normal secretion in small amounts. How do we get the pharmacologic dosing of glucocorticoids? Large doses for meds. What do mineralocorticoids do? Sodium and water homeostasis via RAS and affect cardiovascular system. Tell me about hydrocortisone, which is synthetic cortisol. Some mineralocorticoid effects, few adverse effects at replacement doses. Glucocorticoid side effects indicate that the dose is too high. Extra doses needing during times of stress and illness. Tell me about fludrocortisone, which is a mineralocorticoid replacement and adrenal insufficiency. Hypertension and edema indicate that a dose is too high. Monitor vital signs, weight, and FNE. Okay, now we're going to talk about reproduction. All right. What type of drug class is estrogen? It's a hormone. What is estrogen produced by? Ovaries and placenta. What is the action of estrogen? Stimulates uterus blood flow and growth of uterine muscle. What does estrogen protect against? Osteoporosis. What are the side and adverse effects of estrogen? Can cause hot flashes and potentially DVT. What do we need to consider when someone's taking estrogen? Clients are at an increased risk for blood clots if they take estrogen and for endometrial cancer. All right, what type of drug class is progesterone? Hormone. What is progesterone produced by? Ovaries and placenta. What is the action of progesterone? Suppresses contraction of smooth muscle while baby is growing. What are the side and adverse effects of progesterone? Constipation, teratogenic effects, breast cancer. What is progesterone used for? hormone therapy, dysfunctional urine bleeding, and infertility. Tributaline, what is the drug class? Tocolytics, selective beta-2 adrenergic agonist. What is the action of tributaline? Decreases the frequency and intensity of uterine contractions to suppress but not prevent preterm labor. Decreases myosin LC kinase enzymes that stimulate uterine contractions. What are the side and adverse effects of tributaline? Pulmonary edema. How do we administer tributaline? Subcutaneous injection. What vital sign are we monitoring with tributaline? Heart rate, we don't want it to exceed 120. How long are we dosing tributaline? No longer than 48 hours. Nifedipine is what type of drug class? Tocolytic is a calcium channel blocker. What is the action of nifedipine? Safer than terbutaline, it decreases intensity and frequency of contractions, decreases myosin LC kinase enzymes that stimulate uterine contractions. What are the side and adverse effects of nifedipine? Can compromise utero-placental blood flow, so when baby is born, focus on ventilation to help restore circulation. How long does nifedipine last in the body? 48 hours, and sometimes you can take it at home. All right, magnesium sulfate. What is the drug class? Sulfate. What is the action of magnesium sulfate? Inhibits the release of acetylcholine at neuromuscular junctions and relaxes smooth muscle. What are the side and adverse effects of magnesium sulfate? Muscle weakness, hypotension, headache, dizziness, and hypotonia in the baby, which is loss of muscle tone. What are we going to monitor when taking magnesium sulfate? Blood pressure and respiration. And why do we take magnesium sulfate? Stop premature labor. Oxytocin or Pitocin is what drug class? Hormone. What is oxytocin? Its mechanism of action? Increases force, frequency, and duration of uterus contractions. What is oxytocin used for? Post-term inductions or labor that isn't progressing. What is the side and adverse effects of oxytocin? Water intoxication. So like hold on, IV fluids, and swell. What is oxytocin contraindicated in? Uterine rupture, more than 5 births, active genital herpes, fetal distress, fetal cord lapse, any placental abnormalities, water intoxication. What are we going to monitor when someone's taking oxytocin? We're going to monitor mom's blood pressure, heart rate, temperature, respiratory rate, O2 sats, force of contractions on the TOCO monitor, and we're going to monitor the baby's heart rate, med and labor tolerance, and fetal tracing. All right, misoprostol is what type of drug class? NSAID prostaglandin analog. How do we administer misoprostol? Rectally. All right. What is the action of misoprostol? Promote cervical ripening, thins the cervix to help stimulate contractions. What is misoprostol used for? It's used to induce labor. What are the side and adverse effects of misoprostol? Hypovolemia and decreased LOC. Methylergonavine is what type of drug class? Ergot alkaloids. How do we administer methylergonavine? POIM-IV. What is the action of methylergonavine? Most effective uterine stimulant, last resort because of severe hemorrhaging because of hypertension. What are the side and adverse effects of methylergonavine? High risk for hypertension, convulsions, and death. When is methylergonavine contraindicated? When baby is inside moms. What are the serious complications of oral birth control pills? Abdominal pain, chest pain, headaches, eye problems, severe leg pain. All right, tell me about oral contraceptives. Say estrogen or progesterone combo or just progesterone. Tell me about transdermal contraceptives. Say combo hormone. Tell me about implant contraceptives. It's progesterone hormone and is long term. Tell me about injection contraceptives. Progesterone only and it's long term. All right. What meds decrease contraceptive effectiveness? Rifampin, ritonavir, antiepileptic drugs, grapefruit, and St. John's wort. What meds do contraceptives decrease the effectiveness of? Warfarin, insulin, oral hypoglycemics. All right, what drugs keep the baby in? Indomethacin, nifedipine, magnesium sulfate, tributaline. What drugs are used to induce labor? Oxytocin. All right, what are some examples of category A pregnancy drugs? Thiamine, levothyroxine, dextromethorphan. What are some examples of category B drugs? Amoxicillin, metformin, hydrochlorothiazide, metronidazole, and clindamycin. What are some examples of category C drugs? Tramadol, gabapentin, amlodipine, trazodone. What are some examples of category D drugs? Lisinopril, alprazolam, losartan, phenytoin, lithium. What are some examples of category X drugs? Warfarin, methotrexate, valproate. All right, so the normal thyroid function regulates metabolism, heart function, and growth and development. Pituitary secretes TSH, and then TSH stimulates thyroid to make T3, which is turned into T4. Hypothyroidism has increased TSH but decreased T3 and T4. It's caused by a dysfunction or cervical removal of thyroid gland. You'll see low metabolism and vital signs, and they complain of fatigue. Hyperthyroidism, you'll have low TSH but increased T3 and T4. Increased secretion of thyroid hormone, maybe autoimmune disorder or tumors. You'll see high metabolism and vital signs. You'll be restless and anxious. So drugs for hypothyroidism increase T3, T4, and metabolism. They increase the effect of warfarin, decrease the effect of digoxin. They're contraindicated in patients with MI, severe renal disease, and hyperthyroidism. You'll see side effects like hyperthyroidism such as nervousness, insomnia, weight loss, tremors, headache, nausea, vomiting, diarrhea, cramps, tachycardia, palpitations, hypertension, dysrhythmias, angina, and thyroid crisis. You want to monitor vital signs. Takes 1 to 2 weeks for good effects. Administer first thing in the morning before food. check labels before using over-the-counter meds, assess for and report signs of hyperthyroidism, and incurs a med alert tag. Adrenal function. Adrenals secrete glucocorticoids and mineralocorticoids. Glucocorticoids increase glucose availability. They break down protein, they maintain vital signs, and they affect mood and stress. The physiologic dosing is for people with Addison's disease. You give normal secretion in small amounts. Pharmacologic dosing is large doses for meds. Mineralocorticoids is for sodium and water homeostasis via your system. It affects cardiovascular system. Hydrocortisone is a synthetic cortisol. You have some mineralocorticoid effects, few adverse effects at replacement doses. Glucocorticoid side effects indicate that the dose is too high. Extra doses needed during times of stress or illness. Fludrocortisone is a mineralocorticoid replacement in adrenal insufficiency. Hypertension and edema indicate that the dose is too high. You're going to monitor vital signs, weight, and F&E. Estrogen is a hormone produced by ovaries and placenta. It stimulates uterus, blood flow, and growth of uterine muscle. Protects against osteoporosis. However, it can cause hot flashes and potentially DVT. And then clients are increased risk for blood clots if they take estrogen and for endometrial cancer. Progesterone is a hormone. It's produced by the ovaries and placenta. It suppresses contraction of smooth muscle while baby is growing. It can cause constipation, teratogenic effects, and breast cancer. It's used for hormone therapy, dysfunctional urine bleeding, and infertility. Sibutylene is a tocolytic, a selective beta-2-adrenergic agonist. It decreases the frequency and intensity of uterine contractions to suppress but not prevent preterm labor. It decreases myosin LC kinase enzymes that stimulate uterine contractions, can cause pulmonary edema. You give it sub-Q. You have to watch for mother's heart rate not to exceed 120, and dosing can't exceed 48 hours. Nifedipine is a tocolytic, a calcium channel blocker. It's safer than sibutylene. It decreases intensity and frequency of contractions. Decreases myosin LC kinase enzymes that stimulate uterine contractions, can compromise uteroplacental blood flow, so when baby is born, focus on ventilation to help restore circulation. It only lasts 48 hours, and sometimes you can take it at home. Magnesium sulfate is a sulfate. It inhibits the release of acetylcholine at neuromuscular junctions. It relaxes smooth muscle, can cause muscle weakness, hypotension, headache, dizziness, and hypotonia in the baby. You got to monitor blood pressure and respiratory rate, and magnesium is given to moms to stop premature labor. Oxytocin or Pitocin is a hormone. It increases force, frequency, and duration of uterus contractions. It's used for post-term inductions or labor that isn't progressing. It can cause water intoxication. So hold on to IV fluids and swell. It's contraindicated in uterine rupture, more than 5 births, active genital herpes, fetal distress, fetal cord lapse, any placental abnormalities, and water intoxication. I'm going to monitor the mom's blood pressure, heart rate, temperature, respiratory rate, O2 sat, force of contractions on the total monitor. You're going to monitor baby's heart rate, med and labor tolerance, and fetal tracing. Misoprostol is a NSAID prostaglandin analog. You give it rectally. It promotes cervical ripening. It induces labor and thins the cervix to help stimulate contractions. It can cause hypovolemia and decreased LOC. Methylgravanavin is an ergot alkaloid. You give it PO, IM, or IV. It's the most effective uterine stimulant. It's the last resort for severe hemorrhaging because of hypertension. It can cause high-risk hypertension, convulsions, and death. It's not given when baby is inside mother. So serious complications of oral birth control pills can be abdominal pain, chest pain, headache, eye problems, severe leg pain. Orally is the estrogen progesterone combo or just progesterone. Transdermal is a combo hormone. It's a high risk of clots, especially in people who continue to smoke and chronic headaches. Implants, progesterone only long term, and injections, progesterone only long term. So these meds decrease contraceptive effectiveness, like rifampin, ritonavir, antiepileptic drugs, grapefruit, and St. John's wort. But contraceptives decrease the effectiveness of warfarin, insulin, and oral hypoglycemics. Uterine relaxants or tocolytics keep the baby in, such as indomethacin, nifedipine, magnesium sulfate, and sibutylene. These drugs are used to induce labor. Oxytocin. Some category A drugs are going to be thiamine, levothyroxine, dextromethorphan. Some category B drugs are going to be amoxicillin, metformin, hydrochlorothiazide, metronidazole, clindamycin. Some category C drugs are going to be tramadol, gabapentin, amlodipine, trazodone. Some category D drugs are going to be lisinopril, alprazolam, losartan, phenytoin, and lithium. Some category X drugs are going to be warfarin, methotrexate, and valproate. All right, now we're going to talk about glaucoma and stuff. So aqueous humor is produced by what? Ciliary body. What is aqueous humor secreted into? Posterior chamber. What does aqueous humor circulate around? The iris into the anterior chamber. What does aqueous humor exit? Anterior chamber via the trabecular network and the canal of Schlemm. All right. Tell me about primary open-angle glaucoma. You can't see peripherally. Most common form of glaucoma in the U.S. Progressive optic nerve damage. It doesn't have any symptoms until significant and irreversible optic nerve damage has occurred. What are the risk factors of primary open-angle glaucoma? Most important symptom is increased ocular pressure, family history of primary open-angle glaucoma, advancing age, African and South American ancestry. How do we treat primary open-angle glaucoma? Reduced elevated IOP is the only modifiable risk factor, and the principal method is chronic therapy with drugs. How do drugs lower IOP? Facilitate aqueous humor outflow or reducing aqueous humor production. What are the preferred route for administering these types of drugs? Topical eye drops. All right. What is the first line treatment for glaucoma? Beta-Adrenergic blocking agents, alpha-adrenergic agonists, and prostaglandin analogs. What's an example of a beta-adrenergic blocking agent? Timolol. What is timolol used for? Glaucoma. Mainly open-angle glaucoma, and initial therapy and maintenance therapy. What is the mechanism of action of timolol? Lower IOP by reducing production of aqueous humor. What are the adverse effects of timolol? Bradycardia, AV heart block, bronchospasms. What are we monitoring when we're using timolol? Heart rate before and after administering. What patients do we have to be cautious with when they're taking timolol? Patients with heart failure. What's an example of an alpha-adrenergic agonist? Brimonidine or alphagon. What is brimonidine's mechanism of action? Reduces aqueous humor production and possibly increase outflow, and may also delay optic nerve degeneration. What are the side effects of brimonidine? Dry mouth, ocular hyperemia, headache, local burning, itching, blurred vision, can cross the blood-brain barrier and cause drowsiness, fatigue, and hypotension. What's an example of a prostaglandin analog? Latanoprost or Zolatin. What is the mechanism of action of latanoprost? Lowers IOP by facilitating aqueous humor outflow by relaxing ciliary muscles. As effective as beta blockers, but has fewer side effects, so first-line med for glaucoma. 1 drop in the evening is equal to 2 drops of timolol. What are the side effects of latanoprost? harmless brown discoloration of the iris, increased pigmentation of eyelid and eyelashes, blurred vision, burning, stinging, and conjunctival hyperemia. All right, what is the second-line treatment for glaucoma? Cholinergic agonists, carbonic anhydrase inhibitors, beta blockers like timolol, alpha-2 agonists like brimonidine, and prostaglandin analogs like latanoprost. All right, what is carbonic anhydrase inhibitors used for? Long-term treatment of open-angle glaucoma. What is the mechanism of action of carbonic anhydrase inhibitors? Decreased production of aqueous humor. What are the side and adverse effects of carbonic anhydrase inhibitors? Malaise, anorexia, fatigue, paresthesias, may cause acid-based problems, weight loss, and GI upset. What are the contraindications for carbonic anhydrase inhibitors? Contraindicated in pregnancy and teratogenic to animals. All right, what do cycloplegics do? Paralyze ciliary muscles. What do mydriatics do? Dilate the pupil. Allow you to see inside the eye better. Phenylephrine is an adrenergic agonist. What is that used for? Intraocular exam or surgery. So phenylephrine's side effects are what? Blurred vision, photophobia, constipation, bradycardia, CNS effects, precipitation of angle closure glaucoma. All right, tell me about angle closure / narrow angle glaucoma. Precipitated by the displacement of the iris, which prevents the exit of aqueous humor, develops suddenly, is extremely painful, no treatment, irreversible loss of vision in 1 or 2 days, much less common than OAG. You do iridotomies, stuff like that. All right, what is allergic conjunctivitis? Inflammation of the conjunctiva in response to the allergen. What are the side and adverse effects of allergic conjunctivitis? Itching, burning, thin watery discharge. Peak 20 minutes after allergen exposure. How do we treat allergic conjunctivitis? Antihistamines, NSAIDs, and then glucocorticoids. You'll use glucocorticoids short term because of side effects. All right, what are the topical glucocorticoids like the cream, ointment, or gel used for? To relieve inflammation and itching and drying agent. What are the adverse effects of the topical glucocorticoids? Thinning of the skin, stretch marks, purpura, telangiectasia, which is spider veins, hypertrichiosis, which is excessive hair growth, possible systemic toxicity, so like delayed growth in children, adrenal suppression in all age, most likely though with long-term use in higher doses. How do we administer topical glucocorticoids? You're going to put it in a thin film and gently rub into the skin, but don't use occlusive bandages. All right, what is the mechanism of action of cherolytic agents? Promote shedding of the horny layer of the skin. What are cherolytic agents used for? Treat conditions when there is an overgrowth or abnormal thickening of the skin, so the effects range from peeling to extensive desquamation of stratum corneum. All right, oral drugs for acne. What are the antibiotics we use for this? doxycycline and minocycline, then tetracycline or erythromycin. You can also use isotrinitin and then spironolactone. All right, tell me about isotretinoin. Called Accutane, has been taken off the market. Vitamin A derivative, teratogenic. Triglyceride levels need to be monitored. Adverse effects like nosebleed, inflammation of the lips, eyes, drying, itching of the skin, nose, and mouth, pain, tenderness, and muscle, bones and joints, back pain, depressive symptoms, and may pose a risk of suicide. Reacts with tetracyclines and vitamin A. Spironolactone is also K plus sparing diuretic, blocks a variety of aldosterone receptors, blocks androgen receptors, often used after an OTC med doesn't work, and is teratogenic, so contraceptives should be implemented before taking this drug. All right, what does UVA penetrate? Epidermis and deep into the dermis, so it can cause like immunosuppressive, photosensitive drug reactions, photoaging of the skin, things like that. What does UVB penetrate? The dermis, like tanning and sunburn. All right, what is SPF? It's protection against UVB radiation, all right? All right, what is psoriasis? Red patches with silver scales, okay? Symptoms result from accelerated maturation of epidermal cells to excessive activity of inflammatory cells. How do we treat psoriasis? Got like topical drugs such as glucocorticoids, so like vitamin D derivatives, vitamin D analogs, and vitamin A derivative. Then we got systemic drugs, which are conventional agents like methotrexate, glucocorticoids, and cyclosporin. All right. Why do we use methotrexate for psoriasis? Reduces proliferation of epidermal cells, but is highly toxic and should only be used in patients with severe psoriasis. Why we use glucocorticoids for psoriasis? Most commonly used topical drug for psoriasis, suppress activity of inflammatory cells, suppress high-potency formulations, should not be applied to face, groin, axilla, or genitalia, because this may cause glucocorticoid-induced atrophy and secondary infections that may result in skin fold areas. Why would we use cyclosporin for psoriasis? Inhibits proliferation of B and T cells, may cause kidney damage, so it should only be used after other treatments have failed. All right. Local anesthetics. We know what those are. What is the class of benzocaine? Esther, what is benzocaine used on? Skin and mucous membrane. What is the peak effect of benzocaine? Less than 5 minutes. What is the duration of benzocaine? 15 to 45 minutes. What is the class of lidocaine? Amines. What do we use lidocaine on? Skin. What is the peak effect of lidocaine? Less than 5 minutes. What is the duration of lidocaine? 15 to 45 minutes. This one can be injected, so what's the peak effect of lidocaine injected? 2 minutes. What's the duration of injected lidocaine? 30 minutes to an hour. Permoxine is what type of drug class? Other. What do we use permoxine on? Only the skin. What's the peak effect of permoxide? 3 to 5 minutes. What are the adverse effects of local anesthetics? CNS excitation, followed by depression. Excitation may cause seizures, and depression may cause coma and death. All right. Acute otitis media is inflammation of the middle ear. Autolgia is ear pain. You might have fever, vomiting, anorexia, irritability, sleeplessness, and diarrhea. Children may tug or hold affected ear. Maybe viral bacteria or both. Requires pain med. Should receive antibiotics when clearly indicated. All children younger than 6 months, severe symptoms of infection. 80% of cases resolve without infection, without meds, but you can treat it with high dose amoxicillin, increase exposure to smoke or allergens, vaccinate for flu, and vaccinate for strep.